Again, Paul, thank you for all the effort that you put into this course, and been a true pleasure to work with you on this. One other thing that is, since I'm trying to open this thing here right now, I don't even see my mouse. My mouse is gone here. Is this activated? One thing, Paul, is also super important is to understand where your pressure level is. The pumps, you can zero them at the table, and in particular, larger patients with high venous pressures are they're tall on the table, and so it kind of gets you twice. So really checking that at the beginning and be meticulous, is important. And I think, Patrick, it's amazing how much you have pushed forward there. So that's really cool to see. In our hands, it takes roughly an hour, as you know, and you're getting faster. I think there's a lot of cool principles, especially being that plane and sort of that green zone is perfect. Anyhow, I'll talk about posterior endoscopic foraminotomies. My disclosures. And here's, a little study that we did is, so why do patients, hesitate to go in the cervical spine? And here the barriers, really, the mentorship, which I hope we can bring here. Technology, I think there's a ton of new stuff that we saw here right now. Narrow surgical indications, and it will convince you that that probably is not the case and perceived as too risky. So what are the indications for cervical foraminotomies? It's a unilateral cervical radiculopathy from foraminal stenosis or soft disc herniation. We use imaging, CT or MRI, and contraindications are instability, deformity, central stenosis. However, it doesn't need to be a contraindication because you can also do a central decompression at the same time, and ventral foraminal pathology. And I'm going to, at our case sessions later, I'm going to show you a case that actually this can be done. But as you'll see in my prospective outcome collection, there's definitely challenges there. Key anatomy, I think it's important to really understand the cervical, anatomy here right now. We'll be mainly talking about C3 to C7. However, I've done these cases also between C1 and C2. Here's a foramen. So again, in ventral, you have the ancovertebral joint, vertebral artery. Anybody who's done a lot of these cases has seen the vertebral arteries several times. Anybody here? Patrick, have you seen the vertebral artery with cervical foraminotomies?
No, I haven't, and I hope not.
Yeah, just make sure that you're suspicious. If you go too lateral because of the angle, it's not uncommon that you see the vertebral artery. So it definitely is there. And then this image is important because the nerve root sits always on top of the pedicle. For example, if you have 5-6, the nerve root is going to be right on top of the pedicle. That's where you find the nerve root. The surgical procedure is we described. Here's the planning. A most important thing is, have you done all the non-operative treatments? And is there a better way to do it? So, for example, if it's pedicle to pedicle, distance very short, or there's a slip, it's probably better to do an ACDF or a disc arthroplasty. Setup is the same as MIS. I do them prone here. Use a head holder, but there's a lot of people that use, like a horseshoe, something like that. I like to line up stuff, and I think everybody gets their own little system here. The most important thing is also what Patrick has shown, what I'm showing you right now. When you do these ultra minimal invasive surgeries, you have to be consistent. It doesn't matter how you do it, but you want to go in there every time the same way so you can recognize your anatomy and you know exactly how you get there. What we do typically is we cut the angulation of the facet joint and the disc in half, and then this is roughly the approach angle we take, and then you can modify it. If a disc, you can come in a little steeper. If you want to medialize the nerve root, then you come in a little bit more along the disc space. So you can obviously, adjust it. Here's the anatomy, and I'm going to show that. I go fast here because I'm going to show all of this to you in the lab. We call it the V point because it happens to look like a V. And it's right between the inferior articular process and the superior articular process. Here's medial, here's caudal, and we should see this nicely in the lab. We start drilling there. Again, the drilling is much less stressful than with MIS because you have the irrigation there that helps you to push the dura away. Typically, you see the dura first in the inferior space when you drill on the rostral edge of the inferior index lamina. Then you identify the neural elements, the lateral margin, and you can resect the IAP, SAP, unroof, the nerve root. And then this is one of my favorite things here about the cervical foraminotomies. There's no question when you're done because you can typically see the pedicle, the inferior index level pedicle. You take a small kerrison and you bite right along that, unroof that, and you're done once you have the nerve root exposed beyond that lateral aspect of the pedicle. So the end point of this procedure is very, very clear. That's another thing that you can do is you can partially drill down the inferior pedicle, give some more space, and you can also drill down ventral osteophytes, and that's kind of a little bit more questionable when that is should be done, should not be done. I have a couple cases now that we are following in doing that, and for ventral pathology such as that, the question is, is that worth it to mobilize the nerve roots, or is it better just to do an ACDF? Evidence and outcome here. Fellowship trained, we did Dr. Terman and I, we looked at our data. And basically, if you are facile and you can do lumbar endoscopy, it takes you around 9 cases to get reasonable facile in these. If you don't have a lot of experience, it takes 30 cases to get started. So if you want to extend your armamentarium, it takes around 10 cases to get there. Now, a lot of people might ask, how do posterior cervical foraminotomies compare with our standard surgeries that we all do? And so all 3 techniques are effective in treating cervical radiculopathy. The lowest complication rates are typically associated with cervical foraminotomies. Next question is, what are the reoperation rates here? And in this rather large study of almost 800 patients showed that there's no significant differences at the index level following cervical foraminotomies compared to ACDF surgery. So they're durable. And here they looked at what is the price, cost effectiveness, and it actually showed that they're quite cost effective compared to ACDFs because you can, you don't have to pay all the implants and all the other stuff. What about biportal, right? A lot of people nowadays sort of like we're trying to sort of see what can be done uniportal, biportal. There was a recent meta-analysis on that topic. Outcomes are very similar. So they say, now if you look at the data itself, you can see that both neck pain and leg pain was slightly in favor of the uniportal, which makes sense. Going through the fascial planes in the neck with 2 ports is quite extensive, but there was no significant difference. But again, if you look at the forest plots, all of them seem to be favoring the uniportal. Now, I might be slightly biased in that respect, but here we go. One of the first series, 100 patients, they were published by Dr. Rutten more than 10 years ago, and you can see a nice resolution of arm pain. Only 5 patients required operation, 3 endoscopic revisions, and 2 ACDFs. And so then I want to conclude here with a couple of slides from the ECR from our endoscopic spine research group. As I've presented here a couple of times, we are collecting prospectively the data of all of our patients that we are doing surgeries on. I have a whole group, and we just, my research assistant, Catherine, yesterday pulled out those cases, the last 74 patients. A lot of them are very frail, so 50% are frail. 50% use opioids. You can see here, otherwise around 50 years. Here the foraminotomies and here the discectomies. And again, pain duration is very similar between those. EBL is minimal. Operative time, like I think to that comment. So on average, it's 90 minutes, so 1.5 hours. So we are not in Patrick Kim speed land yet, but Patrick is going to join our initiative, so we're going to bring our case numbers, case duration down. So I'm excited about that. And then here's the really interesting data, I think, too, is like if you look at these are the neck scores, and the first bar is 1 week, 2 weeks, 3 weeks, 1 month, 3 months, and then 1 year. You can see that neck pain gets better very quickly, and then gradually gets better during the first year. The dark blues are the foraminotomies, the light blues are the discectomies, and that's really what we have seen also clinically. Cervical foraminotomies take quite some time to get better. So it's really important when you talk to your patient that this is going to be a month-long process, typically that they improve. So you can see that at 1 year, they're actually doing the same or even better than the discs. but it just takes them a long time to get better. And I think it's because we don't address the ventral pathology in some cases, and the nerve root still is draped over that. And it's going to be interesting now that we have more and more technique to address that. But again, that's just something when you talk to the patient, don't expect a home run. This is just takes more time for these patients. Eventually they get, again, a lot of them are very, very pleased with the outcomes. Same with durability. But I think that's one of the most important take-home messages when we looked at the data right now. It's a procedure that takes more time to take. Again, first 3-4 months, and then people see a real good effect of that. Brings us to the conclusions. As we have seen also with Patrick's talk, the technology is rapidly advancing, endoscopes are getting better. The procedures are now standardized, and we constantly sort of add new technologies to it. Cervical foraminotomy is a very good minimally invasive alternative to fusions and disc arthroplasty, in particular with patients with unilateral symptoms. And I think every spine surgeon should have them in their armamentarium. And there's ongoing innovation for tools and techniques that will broaden our indications. And I have a couple cases afterwards in the afternoon that I'll present then. So with that, thank you so much.
That's great, Christoph. I'm always impressed when I see these presentations, because obviously if you can do something through a very small working channel portal, it's obviously better for the patient. I guess when it comes to cervical spine, people are always at a little bit higher threshold, sphincter tone's a little bit higher. And I'll ask the same question, bigger patients, I do foraminotomies, and I typically use a tube, honestly. And I struggle sometimes with localization, but I think you have more leeway in a tube versus endoscopic, because you can move it around a little bit more. You see a little bit more of the surrounding anatomy. I mean, is that an issue for you guys? Like if you're doing 6-7, for example, you can't see the spine at all. Yeah. Maybe just on the AP, but just can't see.
Well, 6-7, my kids would be laughing right now because 7-8-9, right? So, yes, 6-7 is hard. 7-1 is difficult, right? The shoulders are there. Pierce showed us some tricks that we're going to all use, like with the, I'm sure he's going to comment on that. It can be really difficult. Then you have AP x-rays. Honestly, I think the lower cervical, to localize those, are some of the hardest cases where you really count up and down, and it can get really tricky. But once you're on bone and you find anatomy, they're pretty straightforward. So then it gets it's nice. Also, the venous bleeding is much better controlled than with the tube, and you just don't have the dura issues. You can, once you're down there, and you'll see the hope when they get out too, the control that you have down there is much superior, and you're just more in tune with the neural elements. And bleeding is typically not such a big. The bleeding around the nerve root is not such a big issue. The bleeding in the paraspinal muscles can be a little bit tricky sometimes, especially if you get a bleeder during the approach. So.
Any other questions?